All right, good afternoon, everybody. So thank you guys for joining us this afternoon for our webinar. My name is James Hudspeth. I'm an internal medicine physician at Boston University, and I'm joined by my colleagues, Tracy Rabin and Virginia Rowthorn. We'll be talking a bit later on today. We'll be discussing educational equity, improving access to short-term clinical education for non-US physicians. So, there's a picture of me. And just to give you guys a brief overview of where we'll go over the next hour, I'll start off by giving a bit of an introduction to this topic and discussing some of our terms. Virginia will then discuss present regulatory and legal barriers to the types of educational exchanges we're talking about. She'll talk about some examples of state-level regulatory changes that have been passed that make these exchanges easier. And then Tracy will finish with a discussion of one example partnership in the present state, just talking a little bit about what can be accomplished at the moment and how that might be improved. And then we're hoping to have about 15 minutes or so at the end for questions. And I'll take this moment to note that in your webinar interactive thing, there should be a chat function off to your right. If you think of questions as we present, please feel free to type them in there. I will be reviewing those questions around the 40-minute mark or so and trying to come up with several that I can pass to the rest of the panel for discussion. So, as we start our discussion here, I think it is helpful to have a case study and to talk about this from an individual perspective for a moment. You know, my work internationally has been largely in Haiti, where I work around issues of medical education and nursing education. One of my colleagues down there, Dr. S, is a family medicine physician who also works in medical education as well as clinical practice. As her health system has developed more of a focus on non-communicable diseases, and particularly oncology, she has developed a burgeoning interest in palliative care, the process of treating patients with end-stage diseases of whatever variety. This is a very useful skill set for her as well as for the health system she works in. However, she doesn't have the opportunity to get further formal training within Haiti itself, just because that country doesn't have any programs that can do this, unfortunately. She brought this to our attention, myself as well as other US partners. And when we explored what options we had for her, we were told that there were not really, there really was no capacity to have her come here and engage in clinical care, even in a relatively supervised fashion. And we'll dissect this out a little bit more. But this has been a recurrent theme when myself and many of the colleagues who have formed our working group around this, that patients are, clinicians are allowed to come here, but only to do observations. Apologies. All right. Conversely, myself and her other US partners are welcomed to engage in clinical care under appropriate supervision at Haitian partner sites. So there's sort of a fundamental inequity in terms of the relationship here. And it's that question that really drove the development of this working group from CUGH that the members of the webinar were part of, and led us to write a position paper as well as get to this webinar and are leading further advocacy efforts. This question of how can we provide non-US physicians with equitable access to valuable educational opportunities within the United States. And I will just do a brief plug for CUGH here. This working group really came out of a shared question among several members of the education committee. And we've had a great time working together across institutions, across specialties, and across professions to try to come up with both an exploration of the barriers and some thoughts as to potential solutions. So I think it's been a really good example of the networking that CUGH can provide. And I would encourage those who have similar questions to pose them to colleagues either at the conference or on the listservs and try to find like-minded people you can work with. I found it very helpful. So, shifting back to the topic a bit, When we think about these clinical exposures in global health and how often they are happening and who is doing them and what the barriers are to doing them, we actually don't have a huge amount of data. From the US context, focusing specifically on medical personnel, we know the most about medical students. We know about 30% of them will engage in an international rotation during the course of their medical school training. We know a lot less about residents and fellows. There is some data from particular programs or particular fields, but there's a dearth of data cutting across graduate medical education as a whole. And we know even less about practicing physicians, who probably are the predominant type of doctor who go abroad to work on international sites. Despite them being the predominant class, we just don't have a great way to gather data as to the practices of US physicians as a whole. And then this extends to other healthcare professions. Nurses, who are probably the second most likely profession to go abroad, maybe the first by volume, I'm not sure, we don't have data, physician's assistants or physical therapists, etc. We have even less data about the flow of clinicians from the global south to the global north for training opportunities, or from global south to global south. And I do want to note that is, we're going to focus on trying to create more opportunities for physicians from the global south to come to the global north, particularly the United States, to get further education and training. But certainly there are other initiatives underfoot looking at other ways to do this, for instance, global south to global south training opportunities, and those are also useful and should be pursued. This equity issue that I mentioned earlier is pretty stark, and we can see that when global north clinicians go to low and middle income countries, they often face minimal regulatory hurdles in being able to practice clinically there. And sometimes that is because those barriers are relatively low. The country in question says basically, if you're licensed in country X, you can come here and practice with a couple of hoops to jump through. Sometimes that is because clinicians are ignoring the regulatory and legal barriers that they face, which is a bigger issue, and one that actually Virginia did a nice paper on earlier this year in the Annals of Global Health, Not Above the Law, which I recommend people review. Conversely, when colleagues from the global south come to global north countries, there are a range of barriers that they face in terms of being able to practice even in a supervised fashion. And these vary from country to country. For our context, we will focus on the United States just because that's where most of our working group practices and has practice. We're going to focus on physicians, again, driven by what our working group is constituted by, and also recognizing that they are, in the context of the United States, a large portion of global health exchanges. We're going to focus on short-term clinical educational experiences. So sort of experiences lasting a few weeks to a few months, maybe at the extremes up to a year, really looking to build clinical capacity in a particular area, recognizing that for medical students or for clinicians who wish to do residency or fellowship, there are relatively clear paths for them already laid out. And I'll note that the thing we're contrasting this with is this notion of observerships. And this is the predominant experience that clinical personnel presently can obtain in the United States, where you come to a clinical institution and you're allowed to observe clinical care, but you're not allowed to engage in it. And as Virginia will touch upon a little bit later on, engaging in care here means even minimal activities like talking to a patient. So it really constrains people quite a bit as clinicians in their ability to engage in practice. And it kind of undermines a lot of how we do medical training, which really is this apprenticeship model that extends back centuries. So when we talk about this topic, I think there for many of us may be just an apparent value in trying to reduce these barriers. We did as a working group try to think of a couple broad principles that would inform people as to why this is important. And we came up with 3 broad ones. The first and the foremost by far, I think, is the notion that equity in this sort of education helps support international goals for health. So by providing clinicians across the world with the best opportunity to get the education they want, to treat the patients they work with, we are helping to further world health. And I think that just stands on its own and stands as the most preeminent of these. And it's particularly, I think, in this context around developing those higher level skills for faculty. These can be interventional things, cardiac catheterization, other more high-tech procedures, or it can be things like medical education, palliative care, where there often is fewer opportunities for advanced training in low-income countries. It's also worth noting that equity in these exchanges improves the long-term stability of global health partnerships. So talking to colleagues from a range of countries, I think all of us want to be in partnerships that feel fair. And there's something inherently unappealing about being told that while I'm going to allow your residents and faculty and students to come to my institution to work with my patients and to get training from my faculty, my students and faculty and residents can't do likewise at your institution. They're allowed to come and just have a pale shadow of things. And then finally, for those who are maybe in the political class in the United States, there's also an argument to be made that if we have stronger health systems throughout the world, that is to the benefit of everybody, including citizens of the United States, just in terms of the reduction of epidemic disease and increased political stability. I think this is kind of the third and weakest argument of the bunch. Worth noting, two principles as to what the ideal might look like, and you can see more of these in our position paper. If people scan the QR code there on the bottom right-hand corner, that will take you to the link. It is also in the references of the slideshow, and the slideshow will be put up on the CUGH website going forward. So I think there are two main things that an ideal approach would take. One, it has to be safe for the patients and the medical system. And this is just because our administrators in hospitals in the United States are appropriately relatively risk averse. They're very focused on ensuring the safety of our patients. So we recognize that if we're bringing foreign clinicians in to get education in our system, it does have to be with appropriate supervision. And then the other aspect is making sure that the clinicians who do come can, to the extent possible, engage in clinical work and really get that hands-on experience under that level of appropriate supervision. And I'll just note that this is a program, or programs like this rather, exist within Canada and the United Kingdom. So this is not pie in the sky theory, but really is something that other places have put into practice, without any apparent damage to their own medical system. So with that, I'm going to pass it over to Virginia to give us a bit more of the legal perspective.
Thank you, James, and good afternoon, everyone. I'm Virginia Rowthorn. I'm the Executive Director of the Center for Global Education Initiatives at University of Maryland, Baltimore, and I'm a lawyer by training. I joined the team who wrote the academic medical paper that James just referred to, the academic medicine paper that James just referred to look at the legal and regulatory barriers that stand in the way of foreign medical graduates participating in clinical, i.e. hands-on training programs in the US. The type of training program we advocate in the paper is not a residency or a fellowship, and it is not a backdoor to permanent immigration, but rather an opportunity for foreign medical graduates to come to the US to learn a new medical technique or intervention before returning to his or her country of residence. So, as I will describe, there are currently no visa categories for admittance to the US that's designed or would work for this type of training program. Further, not all state medical boards have a licensure category that would allow such trainees to engage in hands-on care. And finally, although we determined it is not a significant problem, many fear that these training programs might lead to medical malpractice claims. So let's discuss the visa issue, I know this is a very complicated chart and you're not meant to be able to read it, but you can read it in our academic medicine paper, but just to show you how it appears in the paper. So to do our analysis, we looked at a number of visa categories to determine if short-term trainees might fit into any of these existing categories. So we looked at the F1 student visa, the J1 alien physician visa, the J1 research scholar visa, the B1 business visa, the B2 tourism visa, the H1B specialty occupation visa, and the H3B training visa. And for each of these visas, we looked at the regulations relating to them to determine the visa's purpose, how it is used in the medical context, how the visa cannot be used, and the requirements to obtain such a visa and how long a person with that visa could stay in the United States. So on the next two slides, I'm going to summarize our analysis of why none of these visa categories that we looked at would accommodate a short-term clinical trainee. And when I use the word mismatch, as you'll see, I'm referring to why this visa category will not work for short-term clinical trainees. So the F1 student visa is used in the medical context for international students entering U.S. medical schools. Evidence of enrollment in an approved medical school is required for this visa. Short-term training programs would not meet the definition of medical school enrollment. So moving on to the J1 alien physician visa. This is used for enrollment in approved residency and fellowship programs, and applicants must prove they have met the stringent requirements to enter one of these programs in order to get this type of visa. Short-term training programs are not residency programs. Moving on to the J1 research scholar visa. This type of visa is for non-clinical, i.e. non-hands-on observation, consultation, teaching, or research. In fact, sponsors that sponsoring someone for this type of visa must confirm that the J1 research scholar will only have incidental patient contact and not engage in hands-on activities. Now, in terms of the B1 business visa, this is for visitors who come to the U.S. for business purposes. But according to the regulations, it can also be used by students, international students who come to the U.S. for elective clerkships at medical schools. In other words, third or fourth year medical electives. By the language of the statute, it cannot be used for training people who already have a medical degree. In other words, physicians, for hands-on training for people with medical degrees. But this category can also be used for, and is currently used for, the medical observerships that James mentioned. The regulation specifically states that the visa is, quote, merely and exclusively to observe, unquote. The B2 tourism visa is for tourism, and it cannot be used for people coming here for training or study purposes. The H-1B visa is for a specific occupation sponsored by an employer, and this is the category that you see most postdocs fit into. Short-term trainees would clearly not fit into this category because they would not come to the U.S. for employment purposes. Finally, the H-3B visa is a training visa for people invited by an individual and organization for the purpose of training in fields such as agriculture, commerce, or communications. But the regulations specifically disallow using this visa category for medical training, and physicians are not eligible for this type of visa. So you can see that no visa category is appropriate for a foreign medical graduate who wants to come to the U.S. for a short-term clinical training program before returning to his or her country. Now, as a lawyer, I was trained to look at laws and regulations and think about whether the language of the law can be interpreted in such a way as to accommodate what I'm trying to do. In other words, to find the wiggle room. However, such an exercise is really not appropriate in this situation because universities are given the authority by the Department of State to serve as visa sponsors. There is really no desire on the part of university immigration officials to be creative in this area, and that is understandable. Doing so might risk their status as a sponsor with what would be disastrous consequences. So in our paper, we made an immigration recommendation. We recommend the development of a new J1 visa category specifically for short-term clinical trainees. Under our recommendation, clinical interaction would be allowed under appropriate supervision. The applicant's credentials would need to be verified. Short-term training would not be creditable toward a U.S. residency or fellowship program. Applicants would have to attest that they would return to their home country or their country of residence upon completion of the training. Applicants would have to provide evidence of licensure or other authorization allowing clinical contact from the state medical board where the training program is located in the U.S. And I am going to come back to this issue of medical boards. The U.S. host institution would have to have a memorandum of understanding with the partnering institution in the foreign medical graduate's home country. And we suggested a 1-year limit for stay in the United States under this visa. Okay, now I'd like to move on to state medical board licensure. As many of you know, as licensed healthcare professionals yourself, medical boards in each U.S. state and territory regulate physicians who practice medicine within the state's borders. States have authority in this area, and each state has its own definition, but as a general rule, the practice of medicine means to engage with or without compensation in medical diagnosis, healing, treatment, or surgery. So there's really no doubt that participants in a short-term clinical training program would require authorization by the state medical board where the training program is located if they are going to touch patients. So I want to share some of the concerns with board licensure as they relate to this topic of short-term training. Again, although each state is slightly different, for the most part, in order to get a full medical license in a state, an applicant must prove graduation from an accredited U.S. medical school or have their international medical school credentials verified, complete the United States medical licensing examination, the US LME series, complete at least 1 year of postgraduate training as an intern or first-year resident, pass a background check, and prove knowledge of oral and written English. So while these requirements do seem appropriate for a fully licensed physician, it is really unrealistic and expensive for foreign medical graduates to go through this process for coming for a short-term clinical visit. Again, this is another quite a complicated chart. It's what appears in the paper, and I'll explain it to you. In our research, we found that 15 state medical boards do grant short-term medical licenses for visiting physicians. These are called either temporary, visiting, courtesy, or special purpose licenses in these 15 states. These short-term licenses do not require applicants to complete all the same requirements that are needed for full medical licensure. Some states specifically created a license category for short-term international visitors. One is Louisiana's short-term international medical graduate training permit. Another is Ohio's visiting clinical professional development certificate. Other states have a license that would be appropriate for short-term visitors, whether the visitor is coming from overseas or another state. And an example of that is North Carolina's special purpose license. So I wanted to look at Ohio's visiting clinical professional development certificate. This license was created in 2012 at the request of academic medical centers in Ohio to allow for short-term clinical training for foreign medical graduates. Under this license, training activities must be supervised by a physician who is licensed in Ohio and can include taking medical histories, conducting physician examinations, performing surgical procedures, administering anesthesia, and doing radiologic studies. Under this license, the licensee cannot do the following things. They cannot write orders or prescribe medicine, bill for services, take a position in a residency program, or have training count, or have the short-term training count toward U.S. graduate medical education, or remain in Ohio to practice medicine after completing the program. So you can see that states do have the flexibility to grant licenses for short-term clinical trainees. However, this license has not been used much at all because of the visa barrier. So another interesting example that I want to share is that of North Carolina and their special purpose license. And I'm sorry that you're looking at language straight out of a statute, but I'll try to break it down for you. As you can see from the first paragraph, this license is for, quote, physicians who wish to come to North Carolina for a limited time, scope, and purpose, such as to demonstrate or teach a new technique, procedure, or piece of equipment, or to educate physicians or medical students. So this would be a short-term training program would fit into that definition. Under the regulation, the North Carolina board may issue a special purpose license to practice medicine to an applicant who holds a full and unrestricted license to practice in at least one other jurisdiction and does not have any current or pending disciplinary other action against him or her by any medical licensing agency in any state or other jurisdiction. According to medical board officials in North Carolina, they specifically drafted the other jurisdiction language to include internationally licensed physicians. So again, this is this license has not been used for international short-term trainees because of the visa barrier. But I did want to show you this because overall we can see that licensure as a barrier is something that probably could be overcome if the visa issue were resolved. And this would likely come about by academic medical centers wanting to host international students or hold a short-term training program and asking their state medical boards to create an appropriate licensure category. In our paper, we shared a recommendation that advocated for states to create a short-term medical licensure category that would be very similar to the Ohio statute that I just reviewed with you. In our recommendation, including the components that you see in Ohio with regard to what physicians under this licensure category would be able to do and what they would not be able to do, we also listed the types of information a state medical board should request from applicants for this type of license, including a copy of the written acceptance into the clinical training program, evidence of the applicant's license to practice medicine in another country, and no criminal record or disciplinary history in the applicant's country of residence. So finally, as we were studying the issue of short-term training programs, we heard in some quarters about fear that international trainees engaged in clinical practice might inadvertently commit medical errors and create a liability for host institutions. And if they did so, questions about who would be responsible for such liability. We conducted legal research and were unable to find any legal case or settlement related to medical malpractice by a foreign medical graduate in a short-term training program, one that was either clinical in nature or observation only. However, importantly, professional liability insurance policies for short-term clinical visitors are readily available on the commercial market and should be purchased for short-term trainees. Between the availability of this type of insurance and the supervision requirements that we included in our visa and licensure recommendations, we believe that the bottom line is that professional liability is not a problem that should hinder the creation of these types of training programs. So that's a review of the legal and regulatory barriers that we have identified and analyzed in our recommendations. And now I'm going to turn the program over to my colleague, Dr. Tracy Rabin from Yale University, to provide an example that she has worked with in her practice.
Great, thank you so much, Virginia. Again, my name's Tracy Rabin. I am an internist and pediatrician here at the Yale School of Medicine, and I am Associate Director of the Office of Global Health in our Department of Internal Medicine. Now that we've heard about some of the background and rationale for focusing on equity in global health education partnerships from James, and some of the regulatory and legal barriers from Virginia, I want to share an example of how my institution has been working to address the issue of equity in global health education within the confines of what is currently allowed via the observership model. And so I'll use the Makerere University, Yale University, or MUYU for short, experience. I am the Yale side co-director of MUYU, have been since 2011. And my colleague, Professor Harriet Mayanja Kiza from Makerere University, is the co-director of the Ugandan side. So just to give you a sense of who is involved in this partnership, so we have the McCarry University College of Health Sciences, which is the health professions arm of the largest public institution in Uganda, and includes the health professions schools that are listed here. Also, we have Mulago National Referral Hospital, which is the highest level of care, offers the highest level of care in the country within the public health system. And this hospital is the teaching hospital, which is affiliated with McCarry. And then lastly, Yale University. Originally, when this partnership started in 2006, our side included our schools of medicine and public health, as well as our physician associate program under the School of Medicine. And then this year, with our third renewal of our Memorandum of Understanding, we were able to formally include our School of Nursing as well. To give you a little bit of historical perspective about the situation. So in terms of clinical training, so at Mulago Hospital, all of the wards were general wards up until 2003. So patients who had special medical needs were receiving them as part of sort of general ward, but also the physicians taking care of them were trained as generalists, some of whom may have developed a special interest in a particular area, but not having had any formal training. And there were no subspecialty fellowship programs available in the country for them to receive that training. There was a pilot program with the Infectious Disease Society of America in 2004 to bring US trainers to provide infectious disease fellowship training. And that's actually how Yale got involved with a former colleague here at Yale. But importantly, as I say here, all the specialists, in fact, were generalists. There also is a considerable amount of research work and research training that happens at McCarry. They have long been a site of major international collaborations. And that main focus of those collaborations has been on research, primarily in the infectious disease realm. And importantly, there were no active collaborations at the time that were focused directly on helping to improve patient care that was happening at Mulago Hospital. And so during this time, this group of 6 individuals got together and started to talk about this issue. And they came up with this vision of creating a mutually beneficial relationship between our 2 universities, with the ultimate goal of improving the quality of patient care on the wards of Mulago Hospital. And the feeling was that if we focus on education, patient care would improve as the human resources were strengthened. And so just to list who is pictured here, so we have Nelson Sewankambo on the left, Moses Kamya, Sam Luboga, and then Majid Sadiq is the 4th from the left. He is the former Yale faculty member who first went to Uganda through the IDSA program. Professor Harriet Mayanja Kisa, who currently is the co-director of MUYU, and then Professor Oscar Rastegar here at Yale. So the objectives of our collaboration are to improve the care of patients through education, training, and applied research. So we focus on these 4 points. We focus on the training of doctors for McCarry and Mulago in areas of critical need as identified by them. We focus on improving education of trainees in both institutions. Ours is a bidirectional capacity building endeavor. We also focus on enhancing selected educational and clinical infrastructure, and finally supporting applied research. And we do that through a co-investigator model where we pair US and Ugandan trainees or faculty who are working on various issues. Now, in terms of the process, which is relevant to what we've been talking about today, so I'll tell you a little bit about how we select those who come for observerships to Yale and a little bit about the logistics. So first, we have been engaged in ongoing conversation with leadership in both the department, so on the university side, as well as leadership in the hospital regarding their priority areas. And given that there has been such robust educational resources around infectious diseases there, what we were told and continue to be told is that really the area we should focus on are in the fields of non-communicable diseases, and that's where our training efforts have really laid. We work together to identify junior faculty who already are functioning as specialists. Initially, when the partnership began, we had brought a couple of individuals who were senior residents in training, but we really moved after the first year to identifying junior faculty, because this way, if somebody has worked in a particular specialty area for a couple of years, they have a much more targeted sense of what it is that they want to achieve from an experience here at Yale. They're able to have very specific goals and also have an idea of how they're going to implement what they have learned when they go back home and return to their jobs. And then once we have identified those faculty, then we work with them to identify their goals, and then work with our Yale faculty to identify faculty mentors here who will best match those goals. As far as logistics, so our collaboration provides funding for travel, for housing here in New Haven, as well as a living stipend. In addition, when individuals come, we usually try to time their visits around a professional meeting so that they can benefit from that opportunity to present to their professional organization here, and try to also provide a little bit of a stipend for materials or books that they may wish to bring home as well. We observe credentialing for the observers formally here at our hospital, as well as a university ID so that they can access our library and other resources. We are able to train them and give them read-only access to our electronic medical record, which allows them to feel like they're much more part of the team and to really read up on the patients that they're seeing together with the teams that they work with. And then we have our occupational health office provides a review and helps out with anything that they may need when they arrive. The observers then cover the cost of their own visa, and we do use the B1 visa, as Virginia had mentioned earlier. They cover the cost of any necessary immunizations that they may need to meet requirements for being in the clinical spaces here in our hospital. And then they're responsible for purchasing some basic catastrophic health insurance, although this is something that's been under discussion with our hospital as to whether we can start providing that for our visitors. So since 2006, just to give you a sense of what has been accomplished, we have brought 28 faculty physicians for a total of 698 physician weeks, which works out to about an average of 6 months per individual. We also bring medical students for 4 weeks a year. We've brought 39 medical students over that time. And we've brought 2 nurse educators and 1 medical librarian as well. We had a reunion a couple of years ago. This is not a picture of everybody, but I wanted to just give you a sense of who's involved. And these are the departments that are involved. So although our collaboration started as a relationship between departments of internal medicine on both sides, this has really expanded over the years to include faculty at both Yale and McCarey in all of these departments listed here, which has been very exciting to see. And certainly for folks who have come here and gone back to have a multidisciplinary community who have had that same experience is something that is very valuable. What I have not shown here are the numbers of U.S. trainees and faculty that have been to Uganda, because that's not really the focus here. But I do want to highlight the bidirectional piece of our relationship. And importantly, also to note that when our Ugandan colleagues come here, they have taught our trainees here at Yale so much. The transfer of ideas and knowledge truly is bidirectional, and that goes for the faculty, but it also goes for the Ugandan medical students who come here. And I truly feel that that is an impactful experience for those students to realize that they come here and they have quite a bit to offer, and our faculty are routinely blown away by just how intelligent and thoughtful they are. So putting up a couple of pictures here of articles that our Yale News has issued about our collaboration. And the point is to just say that our university values and really highlights this, this collaboration. This is not something that is being sort of kept under the rug because we now have folks working as observers in clinical spaces. This is something that we are very proud of here. And I have a link here at the bottom. If you were to visit this URL, you'd read this article that's shown. And this article gives a bit more of a comprehensive description of our program if you're interested in learning a bit more about what we do. Now, our use of the observership model to work with colleagues to build capacity extends beyond the work in Uganda. Actually, the first partnership here at Yale to use this model was a partnership with Kazan State Medical University in Russia, which also was started by my colleagues Majid Sadiq, who's now at the University of Vermont, and Professor Oskar Rastegar, who is here with me at Yale. So this relationship was a Yale-Kazan relationship from 1996 to 2014, and then has now moved to University of Vermont when Professor Sadiq moved. In Rwanda, we have been partnering with University of Rwanda to bring their chief residents here for training, and some of that is educational training, and some of that is through the observership model. We've also brought junior faculty through that model as well. Our partnership in Indonesia is not with an academic institution, but is actually with a primary care clinic. However, bringing the physicians from that clinic to Yale for several months of training to provide some additional skills has been helpful for them in terms of being able to retain providers at their clinic, and then also allows us to ensure the quality of the supervisors when our trainees go and work there. And then finally, there's our work in Liberia with John F. Kennedy Medical Center, which has been very similar to the work in Uganda and Rwanda. So finally, I just have a few additional thoughts about why individuals from academic institutions from both the U.S. and outside of the U.S. should get involved in advocating for some of these regulatory and legal changes that we have talked about. So first off, physician training is hands-on. This is universal. People don't become doctors by sitting and reading books. And, you know, there are certainly the benefits that our colleagues gain from being able to talk to patients, being able to examine patients when they come here. And these are benefits that they would gain if they had the opportunity to engage in that way. But similarly, the U.S. trainees lose out on the opportunity to maximally benefit from having those visitors here when we are not able to examine patients together or hear how they might approach a history taking. Secondly, the current status of things really limits the educational goals that can be achieved. So many of our colleagues, when they are coming, they're interested in hearing about the thought process and how do people approach different situations. But some of what they're hoping to see is how do we apply the new technology that they may have read about but have not seen, and how do we implement certain pieces of equipment. As a workaround, we actually have moved towards partnering with institutions in other countries. So I think about a nephrologist who came here from Uganda to train, who then learned about insertion of peritoneal dialysis catheters in South Africa, and learned about kidney biopsies from an institution in Iran because he was not able to gain those skills here. Certainly this creates opportunities for 3- and 4-way partnerships between academic institutions internationally, which is a positive thing. But not everybody is able to leverage those relationships, and certainly it would be nice to be able to provide that full complement of experiences here. And then the final point that I would make is really, it just has to do with the morality of global health education partnerships. James mentioned this earlier. You know, when we send our residents, when we send our faculty to work with our partners in their countries, they do get licensed in those countries and then are able to interview patients and examine patients and do procedures on patients if it's in the appropriate setting. However, when our colleagues, our faculty colleagues, are coming to the US and not able to even speak to patients on their own. This is just a gross inequity and doesn't seem right. So just to close, I'm going to turn it over to James to moderate our question and discussion period. So thank you very much.
Excellent. Excellent. Thank you so much, Tracy and Virginia. And thank you for the audience members who have been sitting in some questions. I've been trying to collate a little bit and pick out some broad themes to have people address. Just as a quick note on our discussion slide here, we have 3 things that you may be interested in. One is a brief survey for those who are US-based and have the potential that your institution might be interested in working to reduce some of these barriers. Our next step really will probably be on a state level looking at advocacy around changing some of these elements, and maybe on an institutional level as well. Secondly, there's my email up there. We will have the slideshow on the website, and we may have the emails for Tracy and Virginia as well, if they're okay with that. But I want to at least get mine up there so people can reach out to me afterwards if needed, and I can certainly forward things along to them. And then finally, just another plug for the CUGH committees out of which this work sprung. For those who haven't seen it before, like that QR code will take you to the CUGH committee website. So for the first question, I want to send this to Virginia. Virginia, Sandro Danso Bamfo raised the question of why not expand the purview of the B1, and I'll add in the J1 piece to that as well, to include hands-on medical training, or at least not preclude it?
Thank you so much for that question. That's a good question. And I can say, as a member of the team that wrote this paper, that you know, if any of these visa categories were opened up to allow what we're proposing, we would be very open to that. And however, the reason why we ended up making our recommendation to create a new category within the J1 area is because we did consult with a number of people whose main job is working on visa issues at universities. We also spoke to people associated with the State Department, and they all felt that the biggest opportunity for a change and modification was in the J1 visa category, which is specifically for research scholars, professors, exchange visitors on programs promoting cultural exchange. So for, in other words, for professionals. And so that is the area where I think in the future we can see some movement. So although I agree with you, modifying the B1 category, because that's already where the medical observerships sit and where the 3rd and 4th year medical electives in the US for international students sit, and where it might make sense to us, our understanding is the area, the category where there is a likelihood for changes in the J1 category. So I appreciate your question.
Excellent. Thanks, Virginia. And I'll just add in as well, Sandra, that at the present moment, on the federal level, you know, the appetite for expanding opportunities for even limited immigration is obviously quite low. So we've also, you know, had a gestalt that we're better off focusing on institutional and state change for the moment, keeping the visa issue as something that we'll loop back to when there's perhaps a more permissive political climate. So the next question I wanted to give to Tracy. So Tracy, Srikanth Mahankali was curious about, or raised the concern about whether or not these opportunities could promote a brain drain, and if there are things that can be done to help ensure people return to their parent country.
Sure, thanks so much, James, and thanks for the question. So it's a great question. Certainly this is a concern that comes up. You know, we've been very fortunate, and I think this has to do with, to some degree, with how we select the people that we bring for training, as well as how our institution has really, in a comprehensive way, really wrapped its arms around those who have come to work with us here. I mentioned earlier that we quickly transitioned from bringing resident trainees, resident level trainees, to bringing junior faculty. So a lot of that has to do with people having the experience, but also having a job at home that they are coming back to, and the expectation that they are coming back to implement what they have learned. But I think another important piece of that is just because they have left Yale does not mean that the relationships that they've had with their mentors and their peers here at Yale stop. And we have had many instances where people have continued to work together in research capacity or in a scholarly capacity, and certainly continue to communicate well beyond their training periods, and several additional collaborative endeavors that have grown up out of these opportunities for individuals to come here. There have been a couple of papers that have come out around our collaboration that talk about this a little bit more. And so, what we like to think is the fact that our colleagues remain connected with us, that they remain actively engaged, and we continue to support their work intellectually, that has helped to prevent people from leaving. And actually, we're very proud to say that everybody who has come as a faculty member to train here is back in Uganda. All but 2 are working at the university or the hospital, and the 2 that are not are working in the private arena, but they are still teaching medical students who come and work with them, and that's really the goal. So that's my thought on the brain drain issue.
Excellent, thanks, Tracy. And I would just add on to that a little bit as well, to note that one area where our working group we're aware we have a lack of information about this and are looking to improve this, is like that low and middle income country perspective on this topic. We came at this from the US side and from ways to try to reduce barriers that we were seeing active in our partnerships. But you'll note our working group, if you look at our position paper, is all US based people. So I think an important topic that we want to explore going forward is from the perspective of low and middle income country hosts, and recognizing there's a lot of heterogeneity amongst that group. What kind of opportunities would be the most useful from their perspective for their institutions and for their healthcare systems, and trying to get a better angle on that as a way to focus our efforts to try to make solutions that meet those requirements or needs. I'm just going to provide a brief response to another question from Gabrielle Chiquette, which was about whether or not there are any countries we're aware of that have limited our physicians coming in response to our restrictions for their physicians, in sort of parallel to some of the back and forth we've seen on visa issues over the last several years. I'm not aware of anything like that, Gabrielle. We've not done a lot of looking at the regulatory barriers in LMICs thus far. Virginia had a little bit of, or had some papers touching upon that topic earlier, but nothing that I'm aware of. Tracy, next question's for you. So people had a couple of questions about the McCary and Yale connection. I think maybe the 2 ones I'm going to focus on. So one, like in terms of giving them read-only, the observers read-only access to the EMR, does the institution require them to do HIPAA or other training? And then several people have asked how the university is funding or supporting the partnership.
Sure, thanks, James. So with regard to the read-only access to the EMR, so yes, the HIPAA training is part of the training for them to be able to use the EMR, and they actually have to sign a HIPAA agreement as part of getting the observership credentialing in the first place. So yes to that piece. With respect to the financing of the work that we do, there are actually several sources that we are drawing upon. For the faculty who come, we've been very fortunate in that there was a community physician here in New Haven who was very excited about this work, and his family has basically established a fund that has allowed us to support some of the faculty And then there is an alumnus of our medical school that established another fund that has provided some additional support for that. With respect to bringing medical students here, which we also regard as an important part of our work, I would say that our medical school has decided that in exchange for Yale medical students being able to go as under the umbrella of MUYU, being able to go to Uganda and work at Mulago Hospital, our medical school actually funds the Ugandan medical students to come here. They felt that is sort of their contribution to the equity piece, to thank the Ugandan faculty for all the work that they do to supervise our trainees there.
Great. Thank you, Tracy. Virginia, a question for you from Carol McCammon. Just wondering, she was raising the question, are there any active advocacy groups in existence that have access or influence over politicians who would be energetic and supportive of working on the visa issues?
Thank you so much for that question. And I have to say that we are just at the point of trying to either start an advocacy effort ourselves or link with an advocacy effort in this area. There isn't one that I know about. There are several groups that we've identified might be interested in this, from global universities with global health programs to academic medical centers to, of course, there's a piece for state medical boards, but it's just starting. And so we hope partially by sharing the article in this webinar that we can really create a critical mass of people who are interested in this. And I hope some of the people on this webinar will want to join that advocacy effort. It's very nascent and just beginning.
Thanks, Virginia. And yeah, and I would just piggyback on that to both agree and to note that really, for this particular topic, the constituents that are most impacted are people who are outside of our medical system and outside of our country. So they don't really have access to our politicians or the ability to influence things. And consequent to that, really, it's the people who are part of these partnerships, I think, who will have to lead pushes for change. And that can both be us as people involved in global health, be we clinicians, be we program administrators, what have you. But it also hopefully will be some of our universities. And I think Tracy provides a nice example with Yale. When the university really backs a collaboration and is putting it forward as an example of the good they're doing in the world, I think the hope will be that some of those universities will also be willing to try to push for change around regulations that could make those partnerships all the more effective. And I think the glimmer of hope around that really is that we do see that as something that happened in Ohio. Like, those were changes pushed for by academic medical centers there that were effectively passed. So I think there really is a path forward with that regard. All right, I am appreciative of time here, so I think maybe we'll try to do one more question. And I think, so Tamara Joquera from Peru raised this concern just about how they like having, she runs the student exchange program there. They have medical students who come, but the collaborations aren't equitable, in part because the students there are asked to perform the USMLE exams for many of the electives they do in the United States. And I think that raises a really important point, Tamara. I think, the exams that we have our students and residents do in the States, so the USMLEs in particular, are quite burdensome, and they're burdensome enough as it stands for our trainees, let alone to ask people who are in different countries to go through them, both because the process is more complicated, and often many countries you have to go to either the capital or to another country sometimes to perform the exam. But then also the cost is considerable, and especially if you're not in the US economy, footing the bill for a multiple $100 exam is prohibitive for many folks. So I think that's one of the important reasons from our angle, while we want to ensure that these kind of exchanges are bringing over qualified and appropriately picked people with the right supervision, we also want to make the barriers as low as possible with those criteria being met. All right, well, in deference to the hour, I think we'll call it at that. I want to thank both Tracy and Virginia again for being part of the webinar with me. I'd like to thank all of you who are in the audience and encourage you, if you have further questions or questions we did not get to, please feel free to email me and I can connect you with Tracy and Virginia as needed. And then finally, I just want to thank the Consortium of Universities for Global Health, both for providing us with the technical support for this webinar, and then more importantly, providing us with a really rich intellectual environment to engage in these kind of discussions and concerns and to try to improve the quality of our educational partnerships across the world. Thank you so much, everybody. Have a good afternoon.